My name is Kathleen McCrae. I chose to do Alzheimer's disease for my interventional study for Statistics 506. Alzheimer's disease is an irreversible progressive brain disorder that slowly destroys cognitive skills and memory, and it is the most common cause of dementia in older adults. Approximately 5.7 million Americans are living with Alzheimer's disease in 2018. Of the people with Alzheimer's disease, 10% are older than 65. The percentage of people with Alzheimer's disease increases with age. 3% of the people are between 65 and 74. 75%, I'm sorry, 17% of the people are between 75 and 84, and 32% of the people are 85 and older. Of the people who have Alzheimer's disease, 81% are 75 years or older. Alzheimer's disease occurs more often in women than in men, with 3.4 million of the 5.5 million cases in the United States of America. Blacks have 2 times the prevalence of Alzheimer's disease. Hispanics are 1.5 times the prevalence of Alzheimer's disease compared to whites. The proportion of whites with Alzheimer's disease is 11.2, and Alzheimer's disease diagnosis is on the rise, with the burden of the cost to the United States healthcare system on the rise as well, with $277 billion put aside for Alzheimer's disease in the United States in 2018. There are modifiable and non-modifiable risk factors for Alzheimer's disease. Some of these modifiable risk factors occur in childhood, and they are educational achievement. Those with lower education are more prone to have Alzheimer's disease than those with higher education. Head injuries occurring in childhood, poor diet, and physical inactivity have been known risk factors to Alzheimer's disease. The non-modifiable risk factors are age, family history of dementia, APOE epsilon gene 4. The modifiable risk factors in adulthood are smoking, depression, physical inactivity, social isolation and loneliness, which would go alongside with depression, lack of intellectual stimulation, hypertension, hearing loss, and obesity, as well as type 2 diabetes. The graph on this slide shows the odds ratio for each of the risk factors for developing Alzheimer's disease, with a confidence interval of 95% and a p-statistics or significance value of 0.05 or 5%. Also, this slide highlights one study in particular which compared African Americans who were untreated for hypertension and those who were prescribed antihypertensives with good blood pressure control. And this study showed that 43% of those who had controlled blood pressure were 43% lower risk of dementia compared to those that were untreated. Also, those who were untreated or had poor blood pressure with ratings consistently greater than 140 systolically or greater than 90 diastolically had twice the amount of risk of developing Alzheimer's as those who had good blood pressure control. Hypertension is the specific risk factor being targeted for this interventional study. A healthy heart ensures that enough blood is pumped to the brain, while healthy blood vessels enable the oxygen and nutrient-rich blood to reach the brain so it can function normally. To date, interventional studies have been mainly single domain trials, such as this one, which just is going to show hypertension. And these results of these studies have been negative or modest at best. As we know, Alzheimer's disease is a multifactorial risk factor disease and has several modifiable risk factors. Multi-domain interventions that target several risk factors simultaneously will probably be the best for an optimal effect. And an example of this would be a study that correlates smoking cessation, cardiovascular risk reduction such as hypertension, increasing physical activity, as well as cognitive stimulation exercises and how that affects Alzheimer's disease. There's strong evidence from large-scale clinical trials that reducing blood pressure can reduce cognitive impairment in older adults with hypertension. Two studies in particular were large-scale random control studies, the first being the SPRINT, or systolic blood pressure intervention trial, that examined the effect of standard care versus intense blood pressure lowering in about 9,000 non-diabetic individuals. From this study, a sub-study called Sprint Mind looked at 9,361 hypertensive adults with increased cardiovascular risk but without diagnosed diabetes, dementia, or stroke. The results of these studies are promising. In this Sprint preliminary analysis, it reported a reduced risk of mild cognitive impairment, or MCI, and the combined risk of MCI and dementia, but not dementia alone, in the intense treatment group. So the intense treatment is those patients that were had blood pressure systolically less than 120 and diastolically less than 80. The strengths and limitations of these studies are that most of these studies are done on white population. This really is advancing the disparities between race and ethnicities in the United States. Below is links to both the SPINT trial and the SPRINT Mind trial. This study shows the objective of the intervention study that I propose. Blacks have 2 times the prevalence of Alzheimer's disease. Blacks also have higher prevalence of hypertension and its adverse outcomes, and are more intensely treated for it, but they still are more poorly controlled. Significant reductions in the risk of mild cognitive impairment and the combination of mild cognitive impairment and dementia have been shown for the first time through aggressive lowering of systolic blood pressure in both the SPRINT and SPRINT Mind studies. The objective of my proposal is that the objective of my proposal is that would be to determine if the effectiveness of health education program, which includes medication adherence and lifestyle medications, will reduce blood pressure in Black residents in North Philadelphia and ultimately reduce MCI, or mild cognitive impairment, and the combination of mild cognitive impairment and dementia. North Philadelphia has been chosen as the area of interest because of the high population of Black citizens in these areas. 2 neighborhoods in particular are Strawberry Mansion and the Tioga area of North Philadelphia, which have more than 90% Black population. Participants will be recruited through surveys given at local clinics, local health clinics. Blood pressure measurements will be obtained before the study. Participants will be chosen only if they have hypertension, and it won't depend on whether they're receiving active treatment. So those who are hypertensive and on blood pressure medications will still be included in the study as long as their systolic blood pressure is greater than 120 or their diastolic blood pressure is greater than 80. Blood pressure measurements will be taken weekly at the educational sessions for approximately 3 months, and then these participants will be followed for a period of 2 years. The definition of hypertension will be systolic blood pressure readings greater than 120 or diastolic blood pressure readings greater than 80. And the definition of intense blood pressure control will be systolic blood pressure less than 120 and or diastolic blood pressure less than 80. Both of those factors need to be relayed in order to have intense blood pressure control. The internal and external validity of this study will be realized through the reproducibility and generalizability of the study. This study is an example of tertiary prevention as the participants already have high blood pressure. The sample size is calculated from the level of significance for this study. The level of significance will be 5% or 0.05. The power of the study, the power level will be in 90%. The expected effect size, it will be 2. The underlying event rate in the population and the standard deviation in the population equals the observation minus the mean. This is all done to calculate the sample size needed for this study. This study will be using continuous data. So the statistical procedures needed for this study will be a paired t-test. That will be to compare the changes in outcomes after versus before the intervention in study participants. The logistic regression analysis will be used to estimate the odds ratio of normalized blood pressure, 120/80, after the intervention. Anticipated outcomes. I expect the outcome of this study to take approximately 2 years to see any type of real results. Previous studies from community-based research showed significant decrease in blood pressures between 2003 and 2012. These were educational programs in local communities. So for the improvement in proportions of patients with blood pressure control, 33 studies were included, and the effect was 12% of the patients had improvement in blood pressure controlled. 44 studies showed a reduction in systolic blood pressure, with the median effect being 5.4 millimeters of mercury reduction in systolic blood pressure. And 38 studies showed a reduction in diastolic blood pressure, and the median effect of that was 1.8 millimeters of mercury reduction in diastolic blood pressure. I anticipate that the outcomes of this study would replicate these results. Strengths of the study: community-based participatory research, CBPR, is a partnership approach to research that equitably involves community members, organizational representatives, researchers, and others in aspects of research in the process. Community-based participatory research is generalizable with external validity. It's an ethical way to randomize behavior known to be harmful. For this study, high sodium, high fat, high cholesterol foods will all be looked at and provided education on. Community-based participatory research has high impact due to the members of the participants, and it allows evaluation of risks from socioeconomic factors. It can address multiple risk factors, which is what this study is doing with hypertension, and it results in a reduction of the disease burden and disparities in groups of people. Limitations of this study include socioeconomic factors in the neighborhood influencing medication adherence. Other risk factors such as family history will not be recorded. There's a long lead time in initiation of projects for community-based research, participatory research, and effective frequent communication is required. There may be less highly regarded in research community, these type of studies, and all of these contribute to the limitation of this particular study. These are the references that were used for this presentation, and I thank you for your time and listening to my project. Good luck to you all. Thank you.